We're live in 5, 4, 3, 2, 1.
Good evening, everyone. Welcome to the platform of Orthopedic Research Education Foundation India. And today we have our chairman, Dr. John Mukhopadhaya, sir, who is teaching us about JESS fixator. And we are thankful to Ortho TV to stream this one on this platform. So over to you, sir.
Yeah, thank you, Janki, and good evening, everybody. After a gap of 1 week, we restart our sessions on lectures for the DNB and postgraduate students. Okay, I'm going to talk today about differential distraction for the treatment of basically neglected clubfoot, concentrating on the JESS fixators, and talk a little bit about the Ilizarov fixator as well. So I think William Hazlitt way back in the 18th century said that when a thing ceases to be a subject of controversy, it ceases to be a subject of interest. And the fact that there's so much interest in the treatment of clubfoot is a sign that there's still some controversies that exist. Bradford in 1888 wrote that the literature in clubfoot is, as a general rule, that of unvarying success. It's often brilliant as an advertising sheet, and yet in practice, there's no lack of half-cured or relapsed cases, sufficient evidence that the methods of cure are not universally understood. Okay, we're all aware of the Ponseti technique and what it's done to the treatment of club feet. So, for example, in our practice, if you talk about 20 years ago, we were literally operating on one club foot child almost every day. And now that's reduced to, at least as far as soft tissue releases are concerned, it's released to doing one in maybe a year or something like that. And we are doing much more of the Ponseti technique, especially in the early cases. We almost always do the Ponseti technique with a tenotomy at the end and get very good results with it. We've also done it successfully in older patients. So even up to the age of 11, 12, some recurrent feet, we have been able to treat successfully using Ponseti treatment with casting followed by tenotomy or maximum TA lengthening. Okay, the functional results after the Ponseti technique is what it makes it an excellent method and why it's become so popular worldwide, because unlike when we did extensive surgery, the foot tends to be much more supple than if you do extensive soft tissue releases in the clubfoot. However, in spite of this, the reality is that we still see a lot of neglected, half-treated failure cases, ones that have recurred after treatment, recurred because either the feet have been too rigid or there's been poor compliance in terms of bracing or inadequate treatment where the correction has been half done. And then as it goes on and on, the feet can be quite difficult. Some of them are so rigid that in spite of casting, they do not seem to improve. So yes, even in the older child, we do try the Ponseti technique, but every now and then we have to resort to some form of differential distraction and often some bony surgeries. So we also do things like Dwyer's osteotomies, lateral column shortening, medial column lengthening, depending on the type of case that we are dealing with. Okay, so now the differential distraction techniques is based on the principle of Wolff's law and neohistogenesis. That means by stretching the soft tissue, you get a reformation of soft tissue. And the pioneers were really Ilizarov and Magnesian. And Dr. B.V. Joshi from Mumbai and his team in Mumbai developed a small wire external fixator system called the JESS. That means the Joshi External Stabilization System, which initially they started with in the hand, but then modified it for the use in clubfoot with the differential distraction technique. And this was a very much simpler fixator to put on and was then for some time became very popular and then gradually found its place in the treatment of club feet. However, with the Ponseti technique becoming so popular, some of the cases we might have treated with the JESS fixator earlier, we treat with the Ponseti technique. Now, this JESS fixator was further modified by the team of Dr. Lad, Dr. Sudhir Warrior, and Joy Patankar to the UMEX system, where they changed the systems a little bit. Like, for example, you had knurled rods, you had slightly different openings to your bolts, to your Allen nuts, etc. And therefore the clamps, etc. And they became a slightly different apparatus or method, or slightly different technique, but basic principles remain the same. Okay, so basically the JESS external fixator or the UMEX fixator is a relatively simplified apparatus. You don't have to tension the wires as you would do in the Ilizarov fixator, and therefore it's easier to apply. You don't need a lot of equipment to apply it. Okay, and this consists basically of a system of rods. You have the L rods, the Z rods, you have interconnecting rods, you have a number of K wires of different sizes depending on the size of the foot, and you have these Allen clamps which tighten onto these rods, and either the rods or the K wires. You have these distractors of different lengths. The smaller ones are for the foot, and the longer ones are for the connecting the foot to the leg. Okay, and so this is one of the differences. You see, the original JESS fixator had these two holes here, while this modified fixator or the distractor in the UMEX system has this kind of open end to it, where you can just clip it onto the ends and then distract it. So minor modifications and changes. I'm not sure there's a huge amount of difference between one and the other in terms of its application. So when you're applying the JESS fixator, there are basically 3 points of fixation. You have a fixation on the leg, you have a fixation on the hind foot, and then you have a fixation on the forefoot. Okay, so you have 2 wires here, 2 wires in the calcaneum, which are full wires, and in the forefoot you have 3 wires, 1 full wire and 2 half wires. Okay, so the idea is that you don't completely fix the arch of the foot, or the wires don't pass through all the bones in the metatarsal, otherwise the arch will be disturbed, because as you can imagine, the metatarsal heads are in an arched shape and not in a straight line. Okay, so and then you connect them. So you connect the foot rings, wires with these L rods, and then you have the Z rods to connect the wires on the leg. You can add a vertical wire. So this you can see is the Z rod here. On the leg here, you can see the Z rod. You can see the L rods out here. And then you have these various connecting rods between them. And you have the distractors. You have the distractor on the medial side of the foot, the lateral side of the foot, the medial side between the leg and the foot and the hind foot, and the lateral side between the leg and the hind foot, between the Z rod and this rod below. Okay. Now, how it works, because this doesn't have hinges, so you're distracting both sides, medial and lateral. You tend to do the medial at a slightly faster rate, so 4 times a day, and then twice a day on the lateral side. And then at the end of 2 weeks, you need to reposition the thing. Okay, so you reposition the foot. Usually this has to be done under general anesthesia. And then you start distracting again. Another 2 weeks, you would reposition the foot again. And this repositioning is done a bit like the Ponseti. So you put your thumb over the head of the talus and you abduct the forefoot with the metatarsal raise. So then finally you get, as you get it fully corrected, just like in the Ponseti system, the hind foot will then go into valgus, and then you've got your final correction. And once you've got your final correction, you leave the fixator on for the so-called retention phase. Okay, so you keep it in the distracted position, in the corrected position for 2 to 4 weeks. Now, it's difficult to keep it going for very long because everyone gets impatient. And then once you've done that, corrected it, then you put it in a cast. Usually it's because these are older children. At this stage, you can usually put a below knee cast and allow them to walk on it. Okay, so that is the full treatment. And then once you've taken off the cast at 4 to 6 weeks, then you need to brace them. Okay, so I'll go through some examples of patients we've treated using the JESS fixator. Some of them are older cases, some of them are slightly newer cases. Here's one where you can see that the left side is more or less normal, but you can see the deformity on the right side. It's also had a soft tissue release, a full Cincinnati incision release on the right side earlier, but the foot had recurred. And you can see the cavus, the slight varus, and the varus in the heel. Okay, those are the X-rays. You can see the sort of changes on the X-rays. And this is using the fixator. You correct it gradually over a period of time and then finally put it in a cast in a corrected position. And this is a girl at a 4-month follow-up. At a 1-year follow-up, you can see she's able to squat well. The foot is nicely corrected. And this is her 3 years post-op. Again, you can see able to squat quite nicely with a good ability to dorsiflex, nicely corrected feet. And this is a 3-year post-op. And we also, as I'll show you later, we did some tracings of the foot, not a pedobarogram, but just ink pad tracing of the foot to see the pressure, how the foot is delivered. And we'll show you a couple of cases with that. So here's another girl. This is a much more severe case. Again, recurred after 2 or 3 attempts at conservative treatment and surgical release. And the right foot is really very severe. Again, you put it on the JESS fixator, go through the same process of correction, going step by step, sort of positioning of the foot in the OR. Unfortunately, this in children, it has to be done under GA, which is one of the disadvantages. And see this patient with the pre-op pedogram and the post-op, you can see how nicely the foot is now corrected. Okay, so this is what it was like pre-op, and this is what it was like post-op. Okay, this is her at 3 years post-op. Again, able to squat, maybe not fully. There's maybe some restriction of dorsiflexion. Again, very nicely corrected foot out there. Here's another. This is a younger child, but again, a severe deformity. Here, again, using the JESS fixator, we're able to get a good correction. Child is able to squat adequately. You can see the nice valgus in the foot. Again, a later follow-up showing good correction. And how you can see that this is the abnormal foot, this is the normal foot, and this is after correction. You can see the two sides look very similar in terms of the weight-bearing profile of the foot. And this is a 7-year follow-up, again showing that he's maintaining correction. Okay. Now, sometimes this was something we used to do a little more of earlier again, where you had very rigid feet. So I think now we still nowadays do casts before we put them on the fixator, because if the foot is really very deformed, it can become quite difficult to put the fixator on. So we tend to give them a few casts, get them partially corrected, and then put on the fixator. We sometimes add a percutaneous stenotomy or a plantar fasciotomy along with it when we are doing the fixator. And rarely we've not done much recently, but earlier we did quite a few where in the really bad cases, we did a soft tissue release and then combined it with distraction, or even a talectomy in an arthrogrypotic foot combined distraction. So just show you some of the cases. This was a severe arthrogrypotic foot, again, multiple surgeries, multiple treatment. So here we combined a release with the distraction, just distraction. And you can see we were able to correct the foot quite well. And this is the follow-up showing a good correction of the foot. Here's another one. Again, very badly deformed feet. Had previous posterior releases. Here again, we combined a soft tissue release with the distraction to be able to get a good post-op result. And again, follow-up showing a good correction of the foot. And this is an 8-year follow-up here. You can see she's got a good sort of shape to the foot, but is unable to squat fully because the TA has become tight again. Okay, so of course there are complications. Okay, pin track sepsis is the one thing that you need to watch out for, and this is first and foremost is when you put in the wires, make sure that you irrigate adequately so there's not a lot of heat generation. Use good drills to put in your wires. Use sharp K wires. Make a small incision in the skin rather than drive the wires through the skin. Okay, and you can add a sagittal wire in the foot. So that's one of the things which we sometimes modify is a front to back additional wire in the leg to give additional stability. And you can use threaded pins in the calcaneum in the older children. Clawing of toes is probably one of the very common sort of problems that you have to deal with. And this is especially so if you don't take care during the distraction. So you have to keep stretching the toes. Sometimes it could be related to the positioning of the wires if the wire is too close to the joint. So you have to be careful when you put on the wires that they're in the right place. And again, the toes can get clawed, and you need to, every time you take them to the OR to reposition them, make sure you pay attention to it. Use some stretching devices. You can use elastics or a sort of way to stretch the toes out so that they don't claw up again. And it can even be so bad that you can dislocate. You can see here how the MP joint has dislocated in this case, okay, on the right side. So if that happens, you would need to reposition it and put a K wire through that to get it into position. So be careful. These are things which you can avoid during the treatment. You need to keep a close eye on them. Of course, there will be some patients who are not compliant and don't come back in time and then end up with problems. So these are some of the things you need to take care of. Now, the advantages of this is you avoid soft tissue dissection in a lot of cases where you don't do any major releases in the foot. So therefore, you have a better chance of getting a supple foot. You avoid shortening of the foot, which you would do with if you do bony wedge excisions, etc. The apparatus is simple. It's not very expensive. And as I showed earlier, you can combine it with other procedures. Although now we try to avoid extensive soft tissue releases because of the risk of stiffness to the foot. Of course, there are disadvantages. It's important that the patient is compliant. Some children tend to be very good with it, and some children tend to be difficult to manage with the fixator. So this is something which is important to try and assess before you put on the fixator. You need to take care of or the parents need to take care of the pin tracks. And surprisingly, most of them do quite well. We haven't had many problems with the pin tracks because the parents seem to be sort of involved in the management. They are turning the clamps, etc. So they feel involved in the management. It takes time, and especially during the COVID, this became a problem because it was difficult to give children anesthesia every 2 weeks or so, because then it was a question of doing RT-PCR each time and the costs add up, etc. You need to watch it very carefully, supervise the treatment very carefully. And as I mentioned, if the foot is really very deformed, it becomes difficult to apply because you need to get it into a reasonable position. It's not like an illustrop where you can apply it exactly in the position of the foot. Now, we've used the JESS fixator in some unusual situations also. So here's a post-burn deformity that came to us. And you can see how the foot is shaped on so one side it was actually in severe dorsiflexion and the other side was in equinus, as you can see this side, the opposite side. So we could then use the JESS fixator. We did a release here and then use the JESS fixator on both sides. Here we pushed down on this one and here we pushed up and gradually got it corrected to a reasonably good position. So you can see how the foot is now looking in what was a really badly deformed foot, which the child could not even use to walk on. And this is the last follow-up we have. I mean, it's not a perfect looking foot by any chance, but fairly sort of a functional feet where she could put her, get a plantigrade foot and was able to walk and almost unable to squat as well. Okay, now some other cases, this is a pre-op, more recent case. You can see the deformity after a couple of attempts at treatment. And this is with the JESS fixator. You can see how the correction has happened, is able to squat and things like that. So these are the advantages of the JESS fixator, and we can use them in various situations, mostly in the older child. I mean, I think early on we've done it as young as 2 years, but usually we keep it for children older than 4 or 5 years today. Okay, and then we come to a little bit about the Ilizarov fixator. The advantage of the Ilizarov fixator being that it's more versatile. It's a more powerful tool, so you can use it in more rigid feet. You can use it in older children and more deformed foot. So you can apply the fixator in any position that the foot is. And again, you can combine it with osteotomies of the bone. Okay, so this older child, this is about an 11-year-old child, severe deformity, previous surgeries. So here again, very similar to the JESS fixator, you have a leg block of 2 rings, a hindfoot block, which is a U sort of ring where you can have a pre-designed U ring, or you can add on rods to the half ring to make it into a U ring, and then another ring, a half ring for the forefoot. Okay, and you put in olives on the forefoot, olives on the hindfoot, and generally regular wires on the leg. Okay, so that's how we usually do it. And the other advantage is you can put hinges for the distraction on the hindfoot as well as in the forefoot areas. So you can get some kind of, but you need to place your hinges properly. So you can have an unconstrained type of hinge where it doesn't really matter exactly where it is. But while you're doing the correction of the varus, you probably need a more perfectly positioned hinge. So even with this, sometimes what we do is we distract and then do a couple of manipulations. This is a fixator, you can do without it, but if you have any problems with it, we tend to reposition the fixator in OR and do it. So again, you can see here the wires are tensioned. That's one of the differences. And you can gradually correct very deformed feet and get them. So you can see how this child is managing well. It's got a good correction of his foot by now. The positioning of the wires there. And again, this is the X-ray and the clinical result in a 2-year follow-up showing up very well. Again, this is again a longer follow-up at about 4 years with that same child. Here's another child again with a very severe deformity. You can see the scar of the previous surgery. Here again, we've used the ring fixator, and you can see how gradually we can get it corrected. So you have hinges here, we have hinges in the front, and sometimes we put hinges here, sometimes we don't. We just use distraction and correct it. And you can see how supple the foot is at the time when you take out the fixator and put it in a cast. You can dorsiflex it all the way. It's quite supple, get a good correction. And this is the follow-up picture showing a fairly good correction at the end of a couple of years. And this is a 3-year follow-up, again showing a good correction of the foot. I think this is the last case. Again, you can see how severe bilateral deformity. So you can put on the fixators together. This is to show you how we put the olive wires in the forefoot. So one from the medial side, one from the lateral, one from the medial, one from the lateral side. And each of the wires go through only 2 or 3 of the bones, okay? And then those are the fixator wires. And again, you can see even such a severe deformity, you can get corrected nicely with a fairly simple foot at the end of it, okay? And I think this is again severely arthrogrypotic neglected foot, again, treated with the Ilizarov fixator, gradually corrected down to a fairly good correction again. Okay, so I think, so in conclusion, I'd just like to say that we continue to face the challenge of managing neglected recurrent and resistant clubfoot deformities. Differential distraction is another tool in our armamentarium. And I think between the JESS and the Ilizarov, many of these feet can be managed quite well. Of course, as I mentioned earlier, this is not our first line of attack. We would try the Ponseti technique even in the older children. And if there's no response to that, then we would go on to one of these forms of distraction, differential distraction. And again, the real important thing is how you do this in terms of the technique, in terms of how you put in your wires, how you take care of your pin tracks, how the parents take care of the pin tracks as well. And if that can be managed adequately, these they are fairly well tolerated. We've treated a number of children with this and still do in the very difficult cases. Thank you.
So much, sir. It is really great. I think we can ask questions from the postgraduates if you have any. Meanwhile, sir, if I just want to know, in resistant and neglected clubfoot, usually you prefer this technique, JESS fixator. So we have lots of technique for that. So when you used to treat, in which cases that this is one of the best technique for those?
I think, see, there are 2 or 3 things you need to look at. One is the deformity, how bad is the deformity, okay? So if you're doing things like lateral column shortening and medial column lengthening, you can't do that in very severe deformities. Okay, so you need to get it corrected. So those are for milder deformities. So all these Dwyer's and Dilwyn-Evans and lateral column shortening, medial column lengthening are for mildly residual deformities where you can correct the last bit with that. You can't do them for very severe deformities. If you have very severe deformities, you have to either do it by the Ponseti technique. If that is not in the slightly younger children, so between 5 to 7 or 8, we would use the JESS. And in the older ones, we would probably use the Ilizarov. Okay. Now the Ilizarov in the really bad feet, we can combine it with osteotomy. So you can do the 2 ways. One is a U osteotomy, one is a V osteotomy, where you actually percutaneously osteotomize from the calcaneum through the talus, and then a V osteotomy through the back of the calcaneum as well. And then gradually distract the foot through these osteotomies. You get lengthening as well as correction of the foot. So we've done a few, not many, but 3 or 4 of those cases. And that's another way where the thing is really very badly deformed. It makes life a little easier.
So here you have used the term differential distraction initially, that we used to distract from both the sides, medial and lateral. So why not it is one side compression, another side distractions, like in other cases?
Like in what?
Means, sir, in other deformity correction.
Yeah, so because as I said, it depends on certain principles. Okay, you don't want to crush the lateral side of the foot. Okay, you want to distract it and then correct it, and you get new tissue forming it. So by Wolff's law, as you stretch out the tissue, new tissue forms, which then you can gradually correct to the correct position. So that's why it is called differential distraction. Okay, it's not a pure deformity correction by opening wedge or a closing wedge. Huh?
And so one more thing is that in Ilizarov, we used to do the tensioning of the wire. Here we are not used to do that one. I think pre-stress term you have used for that one, sir, for the
yeah. So
wire.
what we do with the wires is what we call. So there are 2 ways of doing. You can do radial pre-stressing or tensile pre-stressing. So when you're putting on your connecting clamps, if you've got the wires, you bend them or you separate them and then put on the wires. So there's some form of pre-tensioning in the wires, but it's not like actual tensioning where you tighten the. So what you do in the Ilizarov is much more effective in terms of tensioning. That those wires are very strong and much harder to bend, etc. Yeah? You can't bend those wires once they are properly tensioned.
And so the metatarsal wire, you have mentioned that you use one complete wire and another one is half up.
So in the JESS technique, what you do is there are three wires which you put into the forefoot. Okay. The proximal wire, the distal wire goes through the first and second metatarsal close to the head, and then probably captures the fifth metatarsal close to the head because it's an arch. The two shorter wires, which are slightly more proximal, go through 2 or 3 metatarsals from each side only. Okay, so you can still maintain a bit of an arch to the forefoot. You put it through all the wires, then you will get a straightening of the arch.
And so preferably where you used to put those wires, like at the base or in the shaft of the metatarsal?
No, you put it near the head and just, so the second one is governed by the size of the hole, the difference in the space of the holes in the distractor. Okay.
And so
near the head, but not into the joint. Okay, and one just proximal about 1 centimeter, 1.5 centimeters proximal to it, parallel to it.
So about 2 to 3 centimeter distance between those two wires. So
no, it's just less than 2 centimeters, 1.5 centimeters.
Okay. And so about
you've seen the distractor, you've seen the distance between the holes. Okay, so that's how much. So you put one wire, then you put the distractor, and then you check where your second wire will go. Put it there.
And so the tibial wire, what is the position in the leg, where it should be, like in the mid part or in the proximal?
No, it's around, so it's junction of middle and proximal third, yeah. Okay, so you want enough space for your distractors, but it shouldn't be so far that your distractors can't do it. So you see that it's not a fixed point or something like that, but roughly that would be where we put.
And so you have mentioned about one axial wire in the calcaneum. So that wire, where it should be?
Along the axis of the calcaneum, from posterior.
From posterior.
Yeah.
So just below
so we have, so the posterior rod that is there behind the calcaneum holds the two L rods connecting the two wires in the calcaneum, and this third wire, which is at the back of the calcaneum, in the axis of the calcaneum.
Huh? Sir, you have shown one PPT, one diagram in that one, sir. So can you, if with that diagram, if you can explain, that will be easier to understand.
Which one?
Sir, for those wires and where it should be placed, that like axial wire you have mentioned, sir, and the proximal, like
the go back to
that one photograph. It was.
Which one shows up clearly?
Yes.
So this shows you roughly where it is. So you can see these two wires are at the junction of the middle third and the upper third, okay? So the knee would be around here. So you can see the knee here, okay?
Yes, sir.
These two, so you can see the one is along the level of the metatarsal head here. That's the long one, and the short ones are. If you see the fixator, it has two holes, okay?
Yes, sir.
So that distance is like that. So this is the first one. The second one will be at distance proximal to the first one. Okay. Similarly, in the calcaneum, you put one in and then put. So you have to be careful of the vessels when you're going in the calcaneum, and make sure that you're in good bone. Okay, and let me see if you have a picture from the back. X-rays.
Yeah.
Okay, so this one you can see, there's one at the back here. Okay, so here's the two. So this is one in the head and the metatarsal. Okay.
Yes, sir.
One is in the head and one proximally. Here's in the middle of the leg here. This is the axial wire, the sagittal wire on the tibia here. Okay, the two calcaneal wires here, and this is the one at the back here. Okay.
Yes.
And basically, as you're distracting, you are. I'll just run this again so it will show you what it does. I mean, this is by the way, I should have mentioned that this is a designed by Dr. Joy Patankar, the late Dr. Joy Patankar from Mumbai. Way back, this was done almost 20 years, I think 15, 20 years ago. So it's actually a very good animation for that time. And by today's standards, it may not be that fantastic, but for that time, it was something quite brilliant. Okay. So again, you can see it's distracting and then you're correcting it. So what you do at the same time is also, just as you do for a clubfoot, is to use the head of the talus as the fulcrum for correcting your deformity. Okay. And you're abducting the foot, and you can see how once you get the correction, the calcaneum moves out of varus and comes into a corrected position. Okay.
Yes. And so, just like Ponseti, we should correct the cavus first, or we do all the corrections simultaneously.
So here we're not specifically correcting the cavus. If you think there's a very severe cavus, you can do a tenotomy. Okay, this is different from early onset clubfoot that you're dealing with the Ponseti, where you can correct the cavus by just raising the first metatarsal head. It doesn't happen in these feet so easily.
Like, sir, what you have done today, that plantar.
That is in some feet where you have a very severe equinus or also a very bad cavus, and that's not correcting by just raising the first metatarsal head. As part of the Ponseti treatment, we might do a tenotomy earlier on and then continue the casting. So those are exceptional situations where you do that. Okay.
So usually, what is the upper age limit for this chest fixators?
So there's no a true limit as such. We've used them in adults also, but it becomes less powerful a tool. So as the foot becomes more rigid and bigger, the less chances you have, and the more problems you're going to have in correcting it with the JESS fixator. You need a more powerful tool for that.
So in literature, when for JESS fixator, there are many examples for the fractures also, like even for the tibial plateau fracture, where there is soft tissue compromise, they have used the JESS fixator and they have shown the result is quite good. So in which all cases of fractures, sir, you prefer to use JESS fixator?
So I hardly use the JESS fixator for fractures. Okay, I do use the Ilizarov. Okay. We have used it for some open foot injuries. Okay. The calcaneal fractures, etc., where the soft tissue. So there we've used the JESS fixator, but I've not used it for other parts of the body. I'm not. So we see. I mean, I'm sure it works well in some people's hands, but we see a lot of complications. I've had to treat a lot of patients who've had JESS fixator either for the shoulder or for the elbow, and then have had some multiple problems for which we've had to then deal with them. So I'm sure the ones that come to me are the bad ones, and people are getting good results with it. But it's not a method which I would use on a regular basis. I have, I think, probably used one in an elbow in an elderly lady where surgery was not practical for whatever reason. I don't know, but I very rarely do we use it for fractures.
So when you apply the JESS, then what are the usually what's the advice we should give to the patient for the care of this fixator?
So maybe you can answer that question.
So that other than pin track and that uh, checking the if there is no loosening, other than that, if there is anything we should tell the patient.
We told you about that. Huh? One is watching the toes.
Yeah.
You can get sores, okay? So when you put the foot plate,
Yeah.
you need to keep taking it out and cleaning it up. Otherwise, we've seen patients developing severe sores from the foot plates, okay, which is supposed to keep the toes straight, but instead, when it claws in, it digs into it and you get sores in it. You have to avoid the flexion deformities in the toes. As I showed you one case, it even dislocated the MP joint. So that doesn't happen one day, it's happened over a period of time. So you need to be watching for it and looking out for it. If you're getting a lot of clawing in the toes, then maybe you should either wait for some time, slow down, let that settle before you continue with the distraction. Okay, pin tracks is something that you need to keep track of. If you get any infection, you may need to change the wires. If it gets loose, you may have to change the wires. But like I said, with care, you don't have to do this very often. Every now and then, yes, but we really had to change wires many times during the treatment. And anyway, you have that opportunity when you're doing the repositioning in the OT to check the wires, and if any of them you're not happy with, you can change it at the same time because they're under anesthesia. That okay?
Yes,
Sir, good evening.
Something to add?
Sir, can you tell a little bit more about the U osteotomy you have done, like in some cases? What is your indication and what is exactly the technique of going through the calcaneum and talus?
Yeah, so these are, so I think the best would be if you go through Paley's articles on them. Okay. There's
Okay.
also the book by Simon where he's actually written that chapter on. Okay. So that shows the technique very well. So basically, it's a V osteotomy extending from just next to the neck of the talus, going all the way down to the calcaneum, and then extending to the hind foot in the calcaneum. Or you do it in the shape of a U. Okay. So V is usually easier than doing the U. The U stays within the bone, so it's a little more difficult to manage that. But the V osteotomy is not that difficult. So that's what we do if we have to do an osteotomy. The indication is really a very rigid and deformed clubfoot, where in spite of casting, you're seeing there's no sort of give. So when you do even the distractor, you're worried about how effective it will be. So when you do the osteotomy, you can do the correction through the osteotomies rather than having to stretch out the soft tissues only. So it becomes a easier thing to correct the deformity.
So what about the subtalar joint? Won't it be affected? Because we are going through the talus from
So
the
you're
talus
not
to the
going
calcaneum.
through the posterior facet, okay? You're going through the back, which is posterior to the posterior facet, and one is going through as the neck of the talus, where there is no real articulation there. Okay.
Okay.
so one thing which
And even if it does affect the joint a little bit, these patients have already got a lot of deformity, and you're only doing them in the ones where you don't think you can correct it otherwise. Okay.
So why not to do, I mean, just I don't know exactly why not to do a tarsectomy in that, the talectomy.
So you get so this is something you need to discuss. Talectomy is different. Talectomy, the foot becomes quite, I think a lot of people have given up doing the talectomy, except in some very badly arthrogrypotic feet, because you're taking off a part of the joint. Okay, the ankle joint goes, yeah. Okay, and the second thing is You can do tarsectomies, you can do wedge tarsectomies, then that further shortens the foot. Okay, so you need to discuss this with the patients. And if they are, plus you're stiffening up the foot more. Okay, here you're not stiffening up the foot anymore, then it already is stiff. Okay.
Right.
So just one question related to that, sir. In case of, sir, if it is a unilateral club foot and we are doing a JESS fixator for that, do we should give some assurance to the parents that the smaller foot may be getting equal to the normal one while constant?
Never. Don't do that.
Okay, sir.
In spite of that, the foot doesn't always come up to the size of the normal foot. Okay. You only, because you get it when you're doing the correction, but you're not actually lengthening the bones. Huh? Okay. So the bones are also short, so they'll always be short compared to the other foot. You're not further shortening the foot, okay, when you're doing, say, lateral column shortening or whatever, but you are not actually lengthening it through the bones or something like that, or through the metatarsals. Then if you do that, then you can, so like when you're doing a V osteotomy, you get some lengthening of the foot.
And so while putting the wires in the forefoot or hind foot, what is the precaution what we used to take? How much far should be from the joint? Like when we are putting two wires in the metatarsal head, then.
So you're talking about the JESS or the Elizarov? They're two different techniques. So in the JESS, they have to be, one has to be more proximal than the other. In the Elizarov, you put them almost in the same level. They're going like that.
Yes.
Okay, from plantar to dorsal obliquely with an olive. Okay, and then you can just put the wires and then position your ring accordingly. Okay.
That is in the Elizarov, sir, and in the Elizarov fixator.
Yeah, in the JESS, you go, one is near the level, so it's about at least 5 or 6, maybe a centimeter proximal to the joint, and then another one is another centimeter proximal depending on your fixator hole. Huh?
Okay, sir. 5 or 6 millimeters, sir, you want?
At least proximal. Okay, you're putting it through the near the head of the metatarsal, through the metaphyseal bone of so you're putting it through that, so you're part of the bone, but not into the joint. Okay, you don't want to put it into the joint because then you'll have more problems. Okay.
So just one more question about that, sir, because you're doing so many of JESS fixator for club foot. In case of any failure, if you have, then what is the option we should have?
Meaning?
Means, sir, if
so
there
you
is
have
failure of treatment.
Treatment, you can redo the treatment if the patient is willing for it, or you go on to bony corrections later on. You can even do a triple arthrodesis in the really bad feet. You can do wedge tarsectomies. That means you do take off a wedge from the dorsolateral part and correct the foot with wires. But those are all salvage situations. Huh?
Okay, so sir, like you have told that with the JESS also you have some combined approach osteotomy. We can do that one. So.
No, we don't do osteotomies with the JESS. We've done earlier soft tissue releases with the JESS, or talectomies in the arthrogrypotic foot with the JESS. Okay, we don't do osteotomy because the JESS is not solid enough to work for osteotomy. That is, I don't think so. It's not designed for osteotomies.
And so, usually, how much time it takes for neglected club foot for
Although we have done metatarsal lengthening just using not the full JESS fixator, but using the wires as in a JESS and a distractor. So we've done metatarsal lengthening with that.
Okay. So how much time we should that patient should be with the fixator when you are treating a neglected clubfoot usually?
So we are talking about around 2 months, 2.5 months. So usually three repositionings in OR at 2-week intervals, that's 6 weeks, plus another 4 weeks of maintenance in the cast, or maintenance in the fixator, and then another 4 to 6 weeks in the cast. So we're talking 3 months, 3.5 months.
And after that, some brace that is for.
Yeah, so then you give them braces depending on the age. I mean, in the smaller child, you can use the foot abduction brace, Steinbeck, or something similar. While in the older children, we just give standard air force in corrected position.
I think
we're having a severe rain and storm here. So the lights have gone off again, but the generator will come back. I think we've done. Have we finished?
Yeah, mostly we have asked whatever I think is important, and if anyone have any other question, you can please ask. I think so. We have covered most of the things, and
Okay, so we'll call that a.
Yeah.
Okay, bye till whatever next week.
Thank you so much, sir. Thank you.